Yeah, good afternoon. At the outset, I'm thankful for this opportunity. I'm going to talk about why ROP screening for residents is a must. As we all know that ROP is a vaso-proliferative retinopathy affecting preterm neonates, and in developing countries like India with variations in the standard of neonatal care, larger and more mature neonates are now at risk of developing sight-threatening ROP. In India, the incidence of ROP is increasing because of improved neonatal survival rate, and the incidence of ROP varies now between 24 to 47% in low birth weight neonates in different studies, and the risk factors that aggravate ROP are these, which all of us know: low birth weights, prematurity associated with septicemia, blood transfusion, multiple gestations, etc. These are the stages of ROP, and the countries with ROP screening guidelines are as shown in these diagrams. And unfortunately, there is different criteria for screening of ROP in various countries. USA, Canada, they have less than criteria of gestational age, less than 30 weeks, whereas compared to European countries which have different standards. Why the residents should be essentially trained in ROP screening is because the burden of the disease in India is huge. There is improved neonatal care leading to increased incidence of ROP, and ROP is a potentially blinding condition. Progression can be halted if we intervene early, and lack of trained ROP specialists at various levels and paucity of resources at community level. So it makes sense to start teaching ROP, the basics of ROP screening. The numbers are spirally rising, and India leads, unfortunately, all nations in the number of preterm neonates annually, with over 3.5 million neonates, a reducing infant mortality rate, and expanding base of neonatal intensive care units. In the rural areas also, the number of neonates requiring ROP screening has dramatically increased. And Kapoor et al. Published in 2014, and he found incidence of ROP computed in babies weighing less than 1800 gram, and the incidence among this group was 13.6%, and compared to the weight in 1500 to 1800 gram, the incidence was found to be around 11.5%. And these are the various screening modalities: binocular indirect ophthalmoscopy, RETCAM, and telemedicine. And we need to train our residents in all these modalities, particularly the first one, which is a basic thing. It's a gold standard for tool for diagnosing retinopathy of prematurity, and these are the various lenses used, particularly the 28 diopter. Indentation is required, but yes, we do have to monitor the child for apnea, bradycardia, tachycardia, and hypothermia. So we add to the armamentarium of the residents. The residents become well versed with the indentation during indirect ophthalmoscopy. They become accustomed to peripheral retinal examination. They become accustomed to neonatal retinal examination, and they also become accustomed to use of different lenses, different magnification, and different fields of view. So the training of residents for ROP should include didactic lectures, fundus examination in adults with indirect ophthalmoscopy with indentation, fundus examination, then sequentially neonates under the supervision of ROP specialists, and independent examination of the neonates with indirect ophthalmoscopy. RETCAM is another tool, and RETCAM 3 and RETCAM shuttle have come into vogue. RETCAM 3 consists of integrated body with monitor, inbuilt keyboard, and whereas RETCAM shuttle is more portable. And RETCAM thus offers a professional way to keep photographic records of ROP screening, which is required in the present scenario where the medico-legal cases are also increasing. Indirect ophthalmoscopy requires good skill, more expertise is needed, and it has. So with the increase in medico-legal cases, it is essential to document fundus images, which can be done by RETCAM. Smartphone-based retinal peripheral examination can also be done in the present scenario, and this is a MI RETCAM which has been invented by Ashish Sharma. It is not very expensive, and it was really successful in objectively documenting ROP in about close to 80% of the patients. Telemedicine imaging is getting more common, where at the peripheral center you can have the residents also, or the other people who can have these images from the RETCAM, and they can transmit it to the central area where the ROP specialist can really see these images and give the opinion. This is Karnataka government program, KidROP, which has become very popular. So these are the globally accepted norms. Because of medico-legal issues, it is very important to screen ROP, and it makes sense to start teaching residents about this ROP screening procedure. We all are aware of the recent judicial judgments where ophthalmologists have been asked to pay as high amount as this as a compensation, and it's in a study done at AIMS which was published, it was found not only the ophthalmic residents, even pediatric residents and nurses can be trained for ROP screening. So if pediatric residents and nurses can be trained for ROP screening, why can't our ophthalmic residents be trained? And they have found that the sensitivity and specificity is, as you see in the first figure on the right side, it is close to about 95%, which is not very much high compared to the pediatric resident. After training and nurses, you will find that is also very close to 88 to 90%. So ROP screening involves active participation also of the neonatologist, pediatrician and allied medical personnel. Giving adequate training, the general ophthalmology residents can then independently and reliably screen the susceptible neonate for stages of ROP that would enhance and improvise the visual outcomes in such baby. Thank you.
Thank you, Dr. Bhalla.